Good morning or good afternoon, everyone, and thank you for joining us for our next webinar, Brief Interventions to Mitigate Suicide Risk, Counseling on Access to Lethal Means. Next slide, please. This is the third in our four-part series on suicide prevention in primary care, and we want to be sure to invite you to join us for our final event in 2 weeks. That's November 7th on caring contacts and patient education and other strategies. All of these events have been recorded and are archived on our Health Insight YouTube channel, and I'll be putting the links to the prior 2 recordings into chat shortly. As we are recording this event, if you object, please disconnect now. Next slide, please. So just a brief overview of our Zoom platform. I want to draw your attention to the icon at the bottom left of your screen, which is where you can make sure that you are muted. Later in the conversation, we'll have a chance for Q&A, and you can unmute to ask your question, but when you're not speaking, please be sure that you are on mute. And if you're joining us by phone, you can do that by hitting *6. The other thing I'd like to draw your attention to is the chat icon on the far right of your screen, and we invite you to chat in questions and comments to our presenters throughout the conversation, and especially at the end when we get to Q&A. Next slide, please. So here are the objectives for our conversation today. I'm not going to go through these in depth, but as an overall, we'll be talking about the efficacy of reducing access to lethal means, particularly during a suicide crisis, and spend a little extra time talking about tips for working within firearm-owning cultures, since that applies to many of us in the Western U.S. Next slide, please. Some questions to run on as you're listening to the presentation today. How do you assess access to lethal means in your practice currently? And how can you increase the confidence of your practice staff to effectively engage patients in these discussions? And I think you'll hear a lot of really great tips and strategies today. Next slide, please. So I'll briefly introduce our speakers. Want to retain as much time as possible for our content, and their full bios will be included in the slide deck that will be distributed after today's presentation. But Kim Myers is with us from the Division of Substance Abuse and Mental Health at the Utah Department of Human Services, where she's the Administrator for Suicide Prevention and Crisis Services. And we also have joining us Marissa Sobelson-Hen, who's an Administrative Fellow currently with Intermountain Healthcare. So Kim and Marissa, I'll turn it over to you now.
Great. So I think that we are unmuted and good to go. Okay, so good afternoon. We're happy to be with you all today. My name is Kim, and as mentioned, this is the third webinar in this 4-part series. And if you haven't caught the last 2, I encourage you to review those. And in particular, the second webinar in the series really lays a good foundation for what we're talking about in terms of embedding a comprehensive strategy for brief interventions to mitigate risk. So it talks about safety plan intervention and the crisis response plan intervention, of which reducing access to lethal means is a key component. But that said, it can also be an effective standalone intervention in terms of reducing risk for people dying by suicide. And so just to sort of introduce the topic, when we talk about lethal means, we are obviously talking about the way that people might end their lives, the things that they might use to die by suicide. And we're talking about environmental strategies to reduce risk, much like we do with many other health and public health issues, such as, changing policies on indoor smoking or strategies around counseling around seatbelt use. And all of what we'll talk about today has really been, the language that we're using has really been developed in partnership with the firearm community, firearm owners, advocates, people in the industry, to make sure that we are talking in a way that is culturally appropriate and communicates what we're trying to communicate with the individuals that we're working with without shutting down conversation. So before we jump into the content, we're going to do a quick poll. So respond by checking all that apply. So we discuss the following types of home health and safety issues with patients regularly. Okay, so we have someone doing specific firearm work. That's good. Some medication storage, firearms. That's great. Yeah. Okay, a few more seconds to, check anything that you engage in terms of talking with patients. So I know from having young kids and visiting our pediatrician often, that these are things that I get talked to in primary care in pediatrics about often. So we talk about choking hazards in the house, fall risks, safe traveling in terms of seatbelts and car seats. So I think that, what we want to say is that the intervention of talking about environmental safety is one that has been commonly employed in primary care settings. And we think this is a great offset. And it sounds like some people are already doing this regularly. Okay. So we talked in previous sessions about the sense of how many people in Utah and in the Intermountain West are dying by suicide, and how that sort of puts us in what's uncommonly referred to as the suicide belt of the United States. So we are a region with very high rates of suicide. And this graph here gives us a sense of how these individuals are dying. And so as you can see, over half of all suicide deaths are caused by self-inflicted gunshot wounds. And the others are split somewhat evenly between suffocation and poisoning, and then a few other methods. So we know when we look at this that when we talk about comprehensive suicide prevention efforts, that a part of that has to be a focus on reducing access to these lethal means of suicide, with a focus on firearms, as that does account for such a large portion. Also, when we look at the overall scope of firearm deaths in the state, we find that 86% of firearm deaths in Utah are suicides. So when we think about firearm safety and a comprehensive approach to firearm safety, we also have to be talking about suicide prevention. And we've worked within the firearm community to come up with this shared sort of understanding that firearm safety or suicide prevention is the key firearm safety issue in our state. And we can see that illustrated here quite clearly. So just as we go into sort of the intervention around counseling on access to lethal means, a quick reminder of safety planning basics and where this fits into that intervention. So we want people to be able to recognize the early signs of a crisis, whether or not there's active suicidal ideation occurring, or just that, things are not going well in my life, and that I need to sort of be aware that a crisis may be developing. And then identify how I can cope with that internally. What are my internal coping strategies? What are external strategies I can rely on, including people and settings that can provide distraction, and then people and settings that can provide support. And if those aren't sufficient, then what are the professional resources I can reach out to? What are the crisis services available? What are the healthcare resources available to me during as a crisis escalates? How do we think about reducing access to lethal means, which we'll obviously talk more about today, and then helping people identify those reasons for living, what are the reasons that they've hung on through this, and how do we sort of elevate those and put sort of a microphone to those during those really hard times in people's lives. So the difference between the other strategies that are involved in safety planning and the idea of reducing access to lethal means is the other strategies are really internal and interpersonal strategies, and the means safety piece is really an external environmental strategy. So traditionally, we have really focused in the field of suicide prevention and mental health and all that, and understanding why is it that somebody might become suicidal, why might somebody attempt suicide, and why might somebody then go on to die by suicide. And it is critically important for us to continue to better understand the why behind suicide and suicide risk. But we also know that it's really important to also consider the how, and how people attempt plays a critical role in whether they live or die, both in the short term of the acute crisis and the attempt, but also in the long term. And we'll touch more on that throughout this discussion. So I'm just going to give a couple examples on means safety strategies that have been proven to be effective over the long term at a population level. So again, if we look at suicide prevention as a comprehensive approach, this is the only piece of that sort of comprehensive puzzle that has been shown to be effective in and of itself. So it really is an important piece. So in Israel, they saw an increase in military suicides in their Israeli Defense Force, and saw this increase that most of it was happening when these soldiers were leaving the base on the weekends. And they said, well, here's something we could try. We can have them leave their weapons on the base as they leave for the weekend, and then they can come back and resume their military training and service, on Monday morning. And when they did that, they saw a suicide rate decrease by 40% overall. And so the lesson here is that a common response to these kind of strategies are, well, somebody will just find another way. And what we can see here is that these soldiers did not just find another way. And if they did, was less likely to kill them. And then they say, well, they'll just do it later when they can get access. And as we see these soldiers come back onto base and have access to those firearms again, that they didn't then use them to take their life. So it was an effective strategy overall at that population level, driven by a decrease in weekend suicides. Another example is in the UK. They saw an increase in suicide deaths by the active ingredient in Tylenol. And so they changed the packaging and the amount that was able to be given out to 16 over the counter and 32 in pharmacies, and then put them in blister packing. And over the next decade, they saw a 43% reduction in Tylenol overdoses. And so this is not something that is totally foreign to us, something that, we can just say, oh, that would happen over there, but we couldn't do that in the US. We actually had a very similar response to the methamphetamine crisis that we experienced, and we started putting allergy medications behind pharmacies and selling them in smaller doses and making people show identification and things like that. So this is something that we can consider in terms of lethal means reduction strategies. So I'm now going to turn the time over to Marissa to sort of talk through the actual counseling on access to lethal means intervention.
Great. Thanks, Kim. And before we move from the rationale for the counseling on access to lethal means into the practical steps we can all take in clinical practice, thought it would be interesting to poll and ask you all, do you have a policy for counseling on access to lethal means when suicide risk is discovered in a patient? Click. And so you can click yes, no, or no policy, but it's part of regular practice. Great. So we're seeing some no's. Oh, got a couple yeses. Great. We'll give a couple more seconds. All right. So it looks like we ended with about 5 no's as well as 2 no policy, but regular practice. So 7 total no's and a couple yeses. So it seems like there might be a real opportunity here. And so hopefully the steps we're going to go through are useful. It would be interesting, perhaps, if we have time in discussion, to hear from some of you about what the reason is for there not being a policy or regular practice, whether it's just not time or discomfort or something else. But I'll leave that for later. So now to move into a quick summary of what we just presented and as we think through the rationale here. So, suicidal crises are not always planned. They often arise very quickly. And we know, and this is shown in this graph, this bar graph, that from people admitted to a hospital after an attempt, that the period from when they were thinking about making an attempt and then actually took action on that thought is not days and weeks and months, but actually just minutes or hours. And 48% of people said it was 10 minutes or less. And of course, many of these people have underlying chronic mental health issues, but it's still that period of rapid escalating acute crisis can arise quickly. And this strategy is really about keeping people safe during that time. The second point that I think Kim helped us understand is that the type of method matters a lot. With firearms, we know here in Utah that about 87% of the time a firearm is used, it will result in a death, which is way, way, way higher than the other leading methods, which are in sort of single-digit likelihood of death. And so there's something very special, if you will, about firearms because they're such a fatal means. There's not time to get help, change one's mind, and to rescue someone. And then thirdly, this is really an intervention worth doing because it's not true that people will just find another way. In fact, 90% of those who attempt suicide and survive will never go on to die by suicide. So a life saved in that short term is usually a life, suicide prevented for forever. Okay. So now we're going to go through 3 fairly simple, not very time-consuming steps that comprise the counseling on access to lethal means intervention. And there's really just some core goals here. And throughout this, as Kim has stressed, we've gotten input from gun owners and gun advocates to ensure that the way we're talking about and helping achieve these storage and environmental changes is done in a way that is normalizing of gun ownership as opposed to in any way judgmental or threatening to the right to bear arms. And so the first goal is really about raising the issue itself. So helping the patient or his or her family understand why this issue matters. Why is it that if adolescent is feeling very depressed or someone is going through a life crisis or maybe even has thought about suicide explicitly, why it is that guns are a really important thing to be thinking about in advance. And so we've provided on the first bullet toward the bottom, some sample language to say, hi, patient, suicidal feelings can escalate very quickly. They can come and go. And we want to keep you or your child or spouse or partner safer by ensuring that there's not quick access to a gun if that crisis occurs. Reminding patients that guns are the leading method of suicide death and medications the leading method of attempt. Obviously, there are circumstances where we don't want to get into talking about means of attempt. We don't want to overexpose people to what is a more fatal means. But again, in talking, especially with parents, we want to be explicit about guns. We don't want to dance around it. The second is to really get into how are guns stored in the home. Everyone's circumstances are different. Many Utahns own not just one gun, but many guns. In addition, the child or the individual of concern might spend time at a neighbor's house or a grandparent's house. So really asserting how are they stored? Are they locked? Is there ammunition nearby? Some simple questions to get a better sense of how accessible those guns are. And we've provided some sample language here that can also be applied to medications, which we'll talk more about in a second. So now that we've raised the issue, the next step is to think about a practical plan that makes sense for that individual or family. And the goal here, as we've emphasized, is really about creating that time and distance between a potential suicidal impulse and a gun. Because we know that it's that time, as Kim gave those examples with the blister packs and the Israeli Defense Force, it's really helping create a space so that someone can avoid that attempt, ideally get help, and never go on to die by suicide. And so it's all about practical steps and about framing that in a way that is appropriate to the individual of concern. So some sample language here is, what some people do in your situation is store guns away from home until they're feeling better. Maybe with someone they trust, at a storage unit, a gun shop, a police department. What are your thoughts about these options? So again, we're sort of voluntarily putting it back in the position of the person to help think through what makes sense for their circumstances and comfort, understanding that it's a real sacrifice for gun owners to give up access to guns in many cases. And we want to respect that and normalize that as opposed to using phrases like remove or get rid of guns or in any way accuse them of something, but instead work with them. The same is true for thinking about things like medications and other methods. If the patient has talked about crashing their car, now might not be the time to allow that, to encourage them to have access to keys. So it's about kind of tailoring the conversation around circumstances depending on how much information is known. In addition, it's really key to be very practical about next steps. So, you know, I hear you saying, Kim, that your sister is going to come take the guns and bring them over to the police department on Tuesday. And so kind of really getting specific about the who, what, where, why, because we know that that's such a key element of behavior change. And just to talk about storage for a second, the most important element of storage, or I should say the most safe element of storage is to temporarily store guns outside of the home. That's kind of the highest on the hierarchy of safe storage. And that could be with a friend or relative, permitted that they don't have other circumstances in which they shouldn't have guns. It could be at a storage facility, at a firing range that offers lockers. It could be with the police department, which we'll talk about momentarily. But that's always the best option. If that's not appropriate or acceptable to the family, storing the guns in the home is another approach. And what we'd encourage there is to keep the guns locked and ideally unloaded and separate from ammunition, potentially to remove a key part of the firing mechanism, like the pin or the slide in the gun. And just again, to kind of take as many steps as possible to put barriers between a person and easy access. With medication, really thinking through with one's physician, so in this case with patients, about what an appropriate amount and toxicity of medications looks like, and encouraging patients to also reach out to pharmacies or poison control if they have more questions as well. Lock boxes are a practical solution here, similar to the gun safes. And again, since lethal medications are the second leading method, or the main leading method of attempt, and one of the key concerns here, you know, locking those up securely is important. And with opiates, as we know, in many states right now, that's a major concern. So naloxone might be a topic to discuss with patients, using these overdose reversal drugs as another means of safety in the home. And then the last step is really documenting the plan, whether that's in an electronic health record, but also making sure that a patient hopefully walks out with something in writing to help guide them in their next steps. And the final step is really the follow-up. We know that the likelihood of that behavior change increases dramatically if there's a follow-up call a few days or a week later. And we've provided some sample language here, you know, checking in, just want to see how the plan is going, you know, around gun and medication storage, anything we can do to help. And that follow-up is an important step.
So again, just in terms of the messaging, what we're really looking for here is creating a common goal. And one of the things that we know with a lot of firearm owning families is that the goal is around protection and keeping people in the home and their families safe. So when we align in that goal, but talk about it from a new angle when we're talking about suicide prevention, and we can often get sort of good buy-in and good partnerships in these strategies. And this is something, again, help develop by gun owners. We want people to understand that while they are concerned about maybe risk from outside of the home in terms of family protection, that sometimes the risk inside the home outweighs the risk from outside the home. And so what are strategies that we can implement in terms of that risk inside of the home, in terms of safety, in terms of storage? This is about conversation, not confiscation, and this is really about partnering and aligning goals. So just as a quick sort of reminder, and this is a way that we can provide patient education, is that we know that there's some underlying foundational risk for people who experience depression, substance abuse, or other mental health problems, but really that the acute risk happens when this is coupled with a life crisis. So things like a breakup. This is a really important one. Relationship difficulties is a key sort of a precipitating factor for increasing that acute level of risk. So really talking about relationships becomes important. Other ones are arrest or legal troubles, financial troubles, troubles at work, anything that makes me feel hopeless, like this situation is never going to get better, or trapped, like I don't have any other options. So any problems that contribute to those feelings, we want to be discussing explicitly as potential for a crisis escalating quickly in the home. We want people to know when we have teens at home, a wise precaution is to always lock up guns, and that's true for both handguns and long guns like rifles or shotguns. Parents can really connect with the idea that teens can be impulsive and teens can make bad decisions in sort of the heat of the moment, right? And so we want to sort of play off that shared experience with young people in terms of brain development and whatnot, and say, it becomes a good idea to keep things locked up so those impulsive moments don't result in this sort of lifelong tragedy. This is just a little bit about the safe harbor law. This is where somebody can go to law enforcement and ask them to store the guns. It might be important for people to know that law enforcement does not keep record. Also, we always want to do patient education around crisis resources. So sometimes, always the crisis hotlines, the suicide prevention lifeline, and that there are specially trained police called CIT officers that if somebody does need to engage law enforcement, it's always wise to ask for a CIT officer to respond. There's a firearm safety tab under the suicide prevention website, utahsuicideprevention.org, that can give more information. And just quickly before we wrap up, we wanted to share a brief sort of PSA video developed by the Firearm Safety Committee of the State Suicide Prevention Coalition that really is highlighting what we're talking about. We're talking about anybody can face a life crisis. Anybody can go through hard times. And just like we've done with normalizing the idea of friends don't let friends drive drunk, some designated driver, hold on to the keys. And we're talking about, friends don't let friends suffer and have access to firearms during those really high crisis times in life. And we can help protect each other from that as a community. So just quickly share this.
Last year I was at my lowest, going through some pretty serious depression. A couple of friends of mine stopped by the house and said they were worried about me. Said they'd feel a lot better if they could hold on to my firearms until things turned around. I think they saved my life.
If your loved ones are struggling, talk to them about temporarily storing their guns away from their home, because things do get better.
Again, really about keeping people safe and alive so that they can continue to enjoy their lives. We also have gun locks available. So if any of you are in a clinic in Utah and want to have gun locks on hand to be able to distribute, to add again to that layers of protection, layers of safety within the home, you can reach out to me. My contact information will be available and we can help facilitate having those available to you. And then we also have patient education material available for this topic. Lastly, we want to share counseling on access to lethal means. This is a brief introduction, but there is additional training
available. Yes, we're just launching. If you are interested in what you just heard and you or colleagues want to see it in an online course and in even more depth, we're just launching a full counseling on access to lethal means training tailored to Utah, available at train.org/Utah. So www.train.org/Utah, totally free, offers clinical medical education credits, and gives a full overview in even more depth than this.
So this is our contact information if you want more information, and if there's any questions, we're happy to open it up for questions.
Great, thank you, Kim and Marissa. Great information, and I know we're running a little bit short on time, but there were some questions. Just wondered if maybe you could clarify a little bit around the storage of gun at police departments. Is that like a permanent surrender? And is there sort of a record that's created that follows someone forward if they choose to avail themselves of that option? Can you maybe comment just a little bit more there?
Yeah, absolutely. That's a great question. So this is the where the description can be found in state code. But what it is a gun owner or their cohabitant in the home can take the firearms to law enforcement and ask them to hold on to them under the safe harbor law. It's sort of a no questions asked. And then that can be done for a period of 30 days and then renewal. And then once the family or the individual or the cohabitant wants the firearms back, they can go request them from the police department. There's no questions asked, and they can be released back to the family. And then the law enforcement agency is required to destroy record of that. So there is no sort of ongoing record keeping.
Great, thank you. I appreciate that clarification. We did have a comment in the chat. I'll just sort of share with you from someone who does have a policy. You had asked earlier on the poll question, and they said that the policy started off with recognizing it's not going to be a comfortable topic, but when you have the patient's overall well-being in mind, it gets easier to ask as part of an assessment or appointment, but it's never as easy. But it also depends on the relationship that you have with the patient. And I thought that was sort of a spot-on observation there that I just wanted to share and see if you have any reaction to.
Yeah, absolutely. Yeah, I think that relationship always makes these tough conversations easier. But again, even in the absence of an ongoing relationship, being able to identify a shared goal and then relate the conversation back to that goal can be a way to sort of bridge that.
Great. Well, I see that we're at the top of the hour, so to respect everyone's time, I do want to say thank you so much to Kim and to Marissa for joining us today, and then also to our participants for joining us. We do have a link for a survey, and we will send that out to you in email in follow-up along with the materials from today's webinar. In the meantime, thank you again for your attention and participation, and enjoy the rest of your day.
Thank you.
Thanks.